Thank you, Dr. Case, and thanks again for the organizers for including me in this wonderful meeting. This morning I was asked to speak about persistent fetal vasculature, whether to operate or not. And let me begin with my conclusions. Persistent fetal vasculature was formerly known as persistent hyperplastic primary vitreous, and it is a very wide spectrum of disease. And it represents the most common cause of unilateral congenital cataract. And it was reclassified from PHPV to PFV in that article that I've listed on the bottom by Mort Goldberg. It's 23 years old now, that article, but it is still a very timely article. It is excellent. I think every ophthalmologist should read it because every ophthalmologist will encounter PFV no matter what subspecialty he or she is practicing in. Whether or not to operate for PFV-related cataract depends on the extent of ocular disease, the duration of cataract, and the particular patient's parents as well. Besides vision, sometimes progressive angle closure is an independent indication for surgery. Now that I've given you my conclusions, let me give you my talk. The eye is heavily vascularized before birth, and of course, the vasculature that's in the ocular media has to disappear for the visual axis to be clear. And it's persistence of this abnormal vasculature, persistence of this vascular and ocular media with subsequent contracture of tissue that causes the disease spectrum of persistent fetal vasculature. If it's just in the, just behind the lens, we can get a cataract. If it's in the retina, it can cause folds and detachment. This illustration is from that article I was mentioning before by Mort Goldberg from 23 years ago. And this second illustration from the same article shows the different spectrum of phenotypes we can see depending on where this persistent vasculature, where the fetal vasculature persists inappropriately, ranging from just a little dot on the back of the lens to frank cataract, frank retinal folds, Peters anomaly, really a huge spectrum of disease. Of course, the lens is the most common part of the eye that's associated by persistent fetal vasculature. And this just shows how the lens is so heavily vascularized, this vasculature has to regress, and any degree of its persistence causes the spectrum of persistent fetal vasculature. So when do we operate for unilateral persistent fetal vascular cataract? We operate if the presentation is early. Mr. O'Keefe touched upon some of the challenges we have with unilateral congenital cataract that has a delayed presentation. We operate if the eye is otherwise not grossly malformed. If you have a persistent fetal vasculature that's causing significant retinal folds or detachment, obviously cataract surgery is not going to be helpful. We also have to be careful in these eyes because the anatomy can be dragged, and sometimes retina is in places we don't normally encounter it, abnormally anterior. This third point is a very important point that maybe isn't highlighted enough. We operate for unilateral PFV-related cataract if the parents understand the required amblyopia management. If you have a family that's not going to comply with the amblyopia management, the only thing you're doing by operating for unilateral cataract is giving a risk for aphakic glaucoma. The postoperative management is critical, and if you have a situation where it's not going to be able to be done, you should think twice before taking out that lens. So here's a child with unilateral cataract in the right eye. The right eye is a little bit smaller. This is common in persistent fetal vasculature-related cataract. This is a patient who doesn't otherwise have ocular abnormalities and is fit for surgery. Here's a patient with more extensive. You can see some of the persistent pupillary membrane there. Behind the lens, it's not obvious now, but when the lens is taken out, you can see dragged ciliary processes. This is another characteristic finding we find in persistent fetal vasculature-related cataract. Here's a more angry, aggressive-looking case. Again, it's a huge range of presentation, a huge range of phenotype in these cases. Here's a child who had actually hemorrhage in the plaque. Again, a very large range of presentation in PFV-related cataract. The basic pathology here is the plaque behind the lens. The plaque, sometimes it's just the plaque that's occluding the lens. Other times it invades the lens and there's actually cataract within the lens substance. Progressive angle shallowing can be an independent indication for surgery. Here's a girl who came late. You can see the left eye. It's smaller, as is common in PFV-related cataract. It's really not, there's really no hope for good vision in her, but her angle is getting shallower and shallower because that membrane behind the lens is growing. And if this angle closes, it's a disaster. So if you have progressive shallowing, that in of itself is an indication for surgery, even if you're not looking for a good outcome. Here's another child with the same situation. Not all persistent fetal vasculature requires surgery. Here's a child with anterior persistent fetal vasculature, and it's resulted in pupillary membranes. Again, the vasculature, this illustration shows how anterior to the lens, there's a vasculature that needs to regress, and if its failure to regress can cause membranes that are quite dense in the pupil. Here's a close-up of the same child. This can look pretty bad, but in my experience, they see quite well. It's very rare that you need to intervene in something like this. You don't need much space to have normal development of vision. Here's a child who has a posterior plaque that's not visually significant. And when you can see when we focus on it, there's a plaque. It's been actually compared to this ruby brittle star, an ocean creature, and you can see how it's kind of has a central area, and then there are spikes around it. If we focus more posterior, there's also a stalk going to the disc. This all looks pretty bad, but actually in this child, it's not visually significant. Here's another child, again, with persistent fetal vasculature, not visually significant, the posterior plaque, nasal on the lens, and you can see a stalk on the disc, persistence of the hyaloid artery, failure of regression. Again, this is not visually significant. Just because it's there doesn't mean that it has to be operated on. This was a very interesting case. This child actually had a persistent hyaloid artery and there was actually blood in it. A very unique presentation. Again, not visually significant. We don't need to do anything about this. Again, it just shows the spectrum of PFV. Here's a 7-month-old noted to have white pupil in the right eye since soon after birth. She has PFV, but she also has extensive retinal involvement. Obviously, this is not a surgical candidate. We have to examine the whole eye. PFV can affect the posterior segment as well. So let me go back now to my conclusions, which I started with. PFV is a very wide spectrum of disease, and it's the most common cause of unilateral cataract. Whether or not to operate depends on the extent of ocular involvement, the duration of the cataract, and the patient's parents. Besides vision, sometimes progressive angle closures independent indications for surgery, because if that angle closes, it's a disaster and it's very difficult to deal with, so we can't let that happen. And finally, all ophthalmologists should be familiar with the article I've highlighted below, which is 23 years old, but really defines this and is as timely today as it was when it was written. Thank you.